You can see my screen, is that right? Okay. Okay, today's discussion is about substance use disorder and sleep disorder. And that's my name and my credential. As you can see, I'm not a sleep specialist. I don't have any disclosure and no conflict of the interest. An objective today is to review the international classification of the sleep disorder and the effect of the substance/medication-induced sleep disorder. Okay. So as you can see, the DSM-5 has the definition of the sleep disorder usually accompanies the several mental illness such as depression, anxiety, cognitive changes. And during the time that we are treating the patient with any mental illness, we need to pay attention to the sleep disorder as well. And we know that the sleep disturbance usually is a risk factor for the several mental and medical disorders, including of the mental illness. We can include the substance use and non-substance use disorders in general. When you look at the DSM-5, they do have several lists of the titles, which is related to the either sleeping too much or sleeping less, narcolepsy, and also some breathing disorders during the sleep time, such as obstructive sleep apnea or central sleep apnea, hyperventilation, hypoventilation. And also there are some of those REM-related evidence that take place, like as nightmares and behavior that happens during the rapid eye movement and sleep, and also the movement disorders that can happen during the sleep. So there's a long list of the sleep disorder in DSM-5 listed as a sleep problem. In general, sleep is divided to 4 different stages. The stage 1 is usually the one that transitioning from the wakefulness to the sleep, which usually is supposed to be 5% of the time of the sleep. Stage 2, which is the majority of the sleep, is when we have that electroencephalographic waveforms of the sleep spindle and co-complex. That usually is a half of the time of the sleep divided to the stage 2. And stage 3 of the sleep is usually the one that is the deepest sleep. And in young people, usually occupies the 20% of the time of the sleep. When we get older, usually the stage 3 gets shorter. And we do have a rapid eye movement and sleep time that is usually a quarter of the sleep time spent on the rapid eye movement. So we call that one REM sleep, and the other stage are non-REM sleep. And these are the 4 distinct times. And these are not going to be, they follow each other, but usually the stage 1 is the beginning of the sleep, and we sometimes in some of those sleep disorder we have a wakefulness in between, and you may have to go through the stage 1 several times, but most of the time when someone goes to sleep and they never wake up during the time of the night, and they go from the stage 2 to stage 3 to the REM, and then come back to the stage 2 and the stage 3 and REM repeatedly. This happens, and in total becomes this percentage. According to the DSM-5, substances or medication-induced sleep disorder, first of all, has to have that severe disturbance of the sleep. That's the first criteria. But the second criteria is if this sleep disturbance took place during or soon after substance intoxication or withdrawal or exposure to that particular medication or substances need to be established. And also that substance and that medication has to have a potential to create that symptoms of the sleep. So if there is any medication or substances that doesn't have an effect on the sleep, that usually doesn't meet the criteria of the substance or medication-induced sleep disorder. And certainly there are other criteria that you have to rule out any other sleep disorder that existed even prior to that use of the substance. You have to rule out those criteria. Now, in DSM-5, also when you make that substance induce or medication induce sleep disorder, you need to specify that if it's causing the insomnia or daytime sleepiness or parasomnia or mixed types, and also the onset during the intoxication or withdrawal or after medication use. But most of the time, the main American Academy of the Sleep Medicine relies on the international classification of the sleep disorder. International classification has a 7 major category of the sleep disorder: insomnia, sleep-related breathing disorder, central disorder of the hypersomnolence, circadian rhythm sleep-wake disorder, parasomnia, sleep-related movement disorder, and other sleep disorder. We go through this list, which is mainly pretty much have a support of the American Academy of the Sleep Medicine. Insomnia is divided to 3 different distinct types of the insomnia: short-term insomnia, chronic insomnia, and other insomnia. And sleep-related breathing disorder, there are 4 major groups on that one: central sleep apnea and obstructive sleep apnea, sleep-related hypoventilation, and sleep-related hypoxemia. When it becomes a central disorder of the hypersomnolence, is usually has to be some kind of the daytime sleepiness that is not due to any other sleep disorder. So relatively, if I don't have a good sleep as a result of the, for example, sleep apnea, I may have a daytime sleepiness. That is not going to be indication of the central disorder of this hypersomnolence. So we need to rule out the other sleep disorder in order to make this diagnosis. As you may heard of the circadian rhythm of the sleep-wake disorder, especially for those people that they are moving from one place to another place, that they do have a different time zone. They usually experience a short time of this disorder, but also other chronic sleep disturbance can cause this circadian rhythm sleep-wake disorder. Then the reason that we need to specify what kind of the disorder we have, because usually the treatment would be different. And as you may heard of the parasomnia, parasomnia is the behavior or movement that take place during the sleep time or any emotional or perception dream. You may have heard of the term that hypnagogic and hypnopompic hallucination, for example, or you may experience it yourself, that sometimes when you are falling asleep or you're getting off of this sleep, you see some hallucination that doesn't exist. And that can be, part of the parasomnia. But if it occurs once or twice is okay, but if it's something that is happening all the time, it becomes a problem for the patient's sleep time. And it can happen during the beginning of the sleep when you are falling asleep, or during the time that you are asleep. Those movement behavior, just like, for example, some people may have a kicking or movement of the arm or leg during that period of time. Sleep-related moving disorders, such as the restless leg syndrome, that is one of the famous one, is usually a stereotypic movement of the during the sleep time, that it can sometimes make the more disturbance situation for the patient to wake up during the time of the sleep several times, or getting some numbness of the legs or arms as a result of the sleeping. That could be related to the sleep-related movement disorder. Now, the effect of the substance or medication on a sleep quality usually is evaluated in two different ways. One is the quality of the sleep, and one is the architecture of the sleep. When we are talking about the architecture of the sleep, we are talking about those stage of the sleep, and usually we can figure out what effect has on the architecture when we do the polysomnography, and during the time of the sleep, we obtain the EEG electroencephalography. But with the quality of the sleep is sleep onset, wakefulness after sleep onset, and the duration of the sleep that needs to be measured. So we go through a different group of the medication and the substances to see what does those medication or substances do to the quality of the sleep and to the architecture of the sleep, because both of them are important. The main thing is during the deepest time of the sleep, which is a stage 3, that is the time that usually brain rests, and the rest of the time brain is active and is working. So during the REM, certainly you are seeing things or hearing things that in your dream, that that is the effect of the brain is active on that one. And on a stage 1 and 2, it's not deep enough for the brain to go to the sleep. So the deepest sleep time is very important. And as you know, if you deprive someone from this sleep, it's the worst, like a torture that you can do to a person. And if those people that they are interested in criminal justice, sometimes they see that an innocent person is kind of, writes down the crime that they haven't done and sign it after a long-term, deprivation from the sleep. And then later on, it will shows up that usually that was the reason, because the brain doesn't work after that time. So the sleeping is very important. The duration of the sleep is different from age to age. As you know, the kids, small babies, they sleep more than the young adult and adult. And also when it gets a little bit older, we also have a length of the sleep is shorter sometimes. But in general, the people that between age of the 20 to 60, 65, average between 6 to 8 hours of the sleep is a necessity for the refreshing our body and our brain. So if the duration of the sleep becomes less than 6 hours, most of the time causes problem in long run. So the first group of the medication is benzodiazepine and non-benzodiazepine receptor agonist. That's usually on a sleep quality part. This medications improves sleep quality, and by reducing the time that it takes for someone to fall asleep. And those long-acting benzodiazepine or any of those non-benzodiazepine receptors, such as Ambien and Lunesta and those medication, they can improve the quality of the sleep by reducing the wakefulness. So you don't wake up too much during the time of the sleep. And also increasing the total sleep time. Sleep architecture, if you're looking at it, so there's certainly stage 1 becomes less and shorter. And stage 2, usually it will increase. And stage 3 does not have too much of the effect on a stage 3 in general. But also benzodiazepine and non-benzodiazepine receptor agonist usually reduces the rapid eye movement. So as you can see, the stage 3 shouldn't be affected by this medication, but we will talk about it a little bit later about how the chronic use of the benzodiazepine may associate with the tolerance. We know that you do develop some kind of the tolerance toward that. And when it becomes to that point, this then usually would not have that much effect on sleep initiation, and also the effect of the benzodiazepine would be pretty much minimal. The problem is when you develop that tolerance, then if you stop taking that medication, it causes the rebound insomnia, and it can cause a withdrawal effect too. As you know, benzodiazepine has a withdrawal seizure, and it can cause problems. There are new medications on the market that they are listed as a hypnotic agent, such as low dose of the doxepin, that they recommend the dose around 6 milligram or 3 milligram can help, or a newer generation of the sleep medication that until today they would say that it doesn't have a significant abuse potential, and also doesn't cause the respiratory depression or having a withdrawal syndrome. Those group of the medication, of course, the doxepin is a tricyclic medication, but they are listed as a orexin receptors antagonist. And those Rexant group that you can see are approved for the treatment of the insomnia. Those medication, maybe you heard of the name Belsomra and Dayvigo and Huiviviga. And those are the medication that the sleep quality improves when they use it. And usually it lasts for 8 hours, and the outcome is good on the sleep quality. It does have the increasing the REM pressure, means that reduces the REM latency. You fall asleep faster, and it doesn't have too much effect on the other stage of the sleep. Alcohol, up to 75% of the people that they are drinking alcohol, they would have a problem with the sleep. And they usually, in an inpatient setting, will see it up to 90% of the patients that they are either coming off of the alcohol or they are having intoxication with the alcohol. They usually have a problem with their sleep. And the sleep quality during the patients that they are withdrawing is not good. Even during the early recovery, around 8 weeks of the after the withdrawal is finished, up to 88% of the patient they have a problem with the insomnia. So insomnia is very common among the patient that they are either using alcohol or they are coming off of the alcohol. During acute intoxication, when we see that it does have it causes the patient to fall asleep faster. I'm sorry. Phone ringing. So during the acute intoxication, when happened, the patient has this sedative effect of the alcohol, which is reducing the sleep latency. and also increases the non-REM sleep stage 2 and 3. But this is the beginning of the night when the patient is intoxicated. And so the first few hours of the night that you fall asleep on alcohol, you have a reduce of the sleep latency, and stage 2 and 3 is longer, and the smaller size of the REM sleep. But when later in the night, all of this is reversed. You have more wakefulness during restless sleep, and some vivid dreams, some anxiety-laden dream, and also the N2 and 3, the stage 2 and stage 3 reduces, and the REM sleep increases. So we may fall asleep faster when we drink alcohol, but we pay the price the same night a few hours later. And for the people that they are using melatonin, usually useful in a circadian rhythm disorder, sleep quality is mainly, when people use the melatonin, reduces the latency, and sleep onset is faster, but it does not really have too much of the significant effect on the rest of the sleep. And most of the research that they have done, it was inconsistent about the effect on the rest of the quality of the sleep. And the architecture is also inconsistent. So we don't know. Some people would have a little bit of the difference in their EEG when they take the melatonin, but most of the people would not show that the same effect. The effect of the cannabis. Cannabis also has this effect the same way that the benzodiazepine and alcohol has. For the people that they are using once in a while, they may see the enhanced slow wave sleep, and also less of the dreaming and REM sleep. But for the chronic user, the tolerance takes place. And when the tolerance takes place, this effect is going to be different. And also, we can have a withdrawal symptoms from the cannabis. And during the withdrawal, sleep is not good. It's an unpleasant dream that can happen. And usually during that time that the patient is stop using the cannabis, we will see the people are complaining about the having these bad dreams and having several weeks of the problem till getting to the good kind of the sleep. So in EEG that they have done, they saw that the slow wave sleep is reduced, and the REM was increased during this phase. This is the phase of the withdrawal. We provide the medication for patients sometimes that they have a seizure disorder, or we use the anti-seizure drugs for the mood stabilizer for the patient. We know that the barbiturate and the phenobarbital, for example, or phenytoin, they can decrease the sleep latency, means that they take it, they can fall asleep easier, and increase the total sleep time, and usually reduces that wakefulness after the sleep onset. Gabapentin and pregabalin, they have a different effect. Gabapentin usually make the patient to have a less of the awakening during the time of the sleep, and pregabalin shows that reduces the sleep latency but increases the total sleep time. And there is a Keppra or levetiracetam that improves the sleep quality in healthy individuals. From the sleep architecture, the older anti-seizure drugs have a variable effect on the sleep architecture. So you cannot rely on the whole group in one thing. You need to see individual medication, what is the effect of it. One thing you keep in mind is any medication that needs to affect the sleep has to reach to the brain. And so that blood-brain barrier is very important barrier for many medications that they cannot reach to the brain. So what you usually do is keep in mind that if the medication is lipophilic, they can cross the blood-brain barrier. So among the medication antidepressant, we have a different group of the antidepressant. Tricyclic usually decreases the latency of the sleep, and also the wakefulness reduces. Some of those tricyclic, such as nortriptyline and desipramine, they don't have that much effect on the sleep. MAOIs, monoamine oxidase inhibitor, usually will have a negative effect, increases the wakefulness, and also decreases the total sleep time. There are SARIs that, such as trazodone and nefazodone, that is used a lot for the helping patient to sleep. They usually have an inconsistency on the effect on their sleep. Some people even they get the trazodone and they are have a negative effect on their sleep. Some people would have that sleepiness. So we need to keep in mind that when the patient is use the trazodone, they may make them more wakeful during the night. SSRIs, in the other hand, they usually, which the fluoxetine, paroxetine, sertraline, citalopram, and escitalopram, those are the SSRIs, increase the wakefulness after sleep onset and decreases the total sleep time. So it's a good timing to say that if you are using the SSRI, it's not a bad idea to tell the patient to take it during the daytime. And also, we know that a small group of the people that they are using medication have different effect, opposite effect. So I usually tell my patient, any medication, if it does make you drowsy, take it in the evening. If it doesn't make you drowsy, take it in the morning. So that way, antidepressant. When it comes to the analgesic medication, the opioid effect on the quality of the sleep is usually different from the individual that they are using it chronically, or they are using it just for the first time and acutely. Among the healthy individual and those that they are using the opioid and they do have a criteria for opioid use disorder, sleep quality is different. In healthy individual, opioids have no effect on wakefulness after sleep onset, and total sleep time doesn't get any effect of that. Among individuals who chronically use opioid increases the wakefulness after sleep and decreases total sleep time. And from the sleep architecture, opioid stage 3 of the sleep is affected and decreased. So the time that the brain gets rest is decreased as a result of the use of the opioid. And in a higher dose, also reduces the REM sleep. And let me make sure that my battery is not too. Few seconds. Go. So opioid may produce an increase in sleepiness in people that they go to the deeper sleep, and reduces the REM and a slow wave sleep during the acute short-term use. So if I'm a naive to the opioid, it can cause me to sleep better. But the tolerance can take place, and when the tolerance takes place, the complaint of the insomnia comes to you. In architecture part of the effect of the opioid, it shows that it reduces the sleep efficiency, and total sleep time reduces, and also slow wave sleep, and possibly the REM sleep is also reduced. We know that the people that they do have obstructive sleep apnea, they have a negative effect of the opioid, and because opioid can exacerbate the obstructive sleep apnea. And also, in a chronic use of the opioid, the research shows that it can cause a central sleep apnea, especially when we are using those longer acting opioids. A stimulant in general, we know that it will make people awake, and it will increase the latency of the sleep onset, and increases the wakefulness during the sleep period. And effect of the CNS stimulant on the architecture of the sleep is the stage N1 sleep increases and reduces the stage 3 and REM. So mainly the deepest sleep, it doesn't exist. Most common stimulant that everybody uses is caffeine, and caffeine can disrupt the sleep, and it does have a antagonistic effect on adenosine. An important regulator of the hemostatic sleep drive is adenosine receptors, and also through effect in circadian timing, caffeine can cause problem. Of course, we know the other stimulant is also causes problem with the sleeping. And there are a group of the antipsychotic, atypical antipsychotic medication that usually is used mainly for the adjunct treatment of some of those mental illness, such as depression and anxiety and PTSD. A small dose of those medication also helps the patient to have a better sleep, reduces the sleep latency, and the wake time after sleep onset is reduced, usually increasing the sleep time. From the sleep architecture, atypical antipsychotic medication usually suppresses the REM sleep and increases amount of the stage 3. So that's a good effect that give you rest in the brain. Quetiapine, ziprasidone, olanzapine, and clozaril, those are the medication that is usually used. Clozaril, of course, is rarely used because of the requirement for the blood work every week in the beginning, and eventually every month. But the quetiapine and ziprasidone and olanzapine has been used a lot for that reason. Now, sometimes we don't pay attention. The beta blockers, for example, we use that one all the time in patient when you're prescribing the sleep quality for those lipophilic beta blockers, such as propranolol, metoprolol, pindolol, is usually increasing in both the number of the awakening and the amount of the wake time. So this is very important when we are prescribing the medication. Usually beta blocker suppresses the REM sleep. An alpha adrenergic agonist such as clonidine shows that on people that they do have a hypertensive problem, decreases the total sleep time. But also to the healthy individual, clonidine increases the sleep time. So that's an effect that you will see if they are treating the patient for the blood pressure problem and giving a clonidine. You may see the patient is complaining of the sleep problem, but generally speaking, if you're using the clonidine on someone for any other reason, such as sometimes we use that medication for people with the opioid use, it may increase the total sleep time. And from the sleep architecture, increases the number of the shift to the stage N1 sleep wakefulness, and also suppresses the REM sleep. Tobacco. chronic tobacco use is usually causes the insomnia, decreases the slow wave sleep, and also have effect in increasing the daytime sleepiness. When you don't sleep good, you have a daytime sleepiness. Withdrawal from the tobacco can lead to the impaired sleep. As one of my uncle, you could set up your watch with them. He would wake up at 3 o'clock in the morning to smoke one cigarette to go back to sleep. So individual that they are smoking, sometimes experiencing this craving at the middle of the night, and that wakes them up at the middle of the night. So my references up to date and DSM-5-TR, and that's our Chris with the hat, my cat. And that's it. Any question or comment?
That was fantastic, Kamran. Thank you so much. That was a great rundown of all kinds of different medications and what they might be doing or be helpful or not be so helpful in settings. That was fantastic. Thank you. That was some things I hadn't even thought about with certain medications like the beta blockers. So anybody have any questions, thoughts, or comments for Kamran about this very meaty presentation?
Hi, everyone. I have a question.
Mhm.
Hi. As far as clonidine, a lot of times we use guanfacine in patients with ADHD. Are the sleep effects similar to clonidine with the sleep delay?
Yeah, that most likely are the same. And the one that they found out that they did some kind of research on it was a clonidine that is usually used, but it listed as all the alpha blockers, the medication group.
Thank you.
Other questions or thoughts?
I have a question, Dr. Troxler, for Kamran.
Mhm.
So, in my experience, just as you mentioned and show the data on the inpatient setting for patients who are withdrawing or completing a detox for alcohol, they certainly have a hard time sleeping. What I find, and I don't entirely agree with, is our providers will initiate quetiapine 100 to 200 milligrams, and then it seems that the patients will kind of end up on that medicine indefinitely, and it'll get prescribed once, and then if they're on quetiapine for years, without having a bipolar disorder or any type of psychotic disorder. So I kind of try to discourage against prescribing antipsychotics off label just for sleep. Any thoughts about this? I know their patients are so desperate for sleep, and they give them this relatively potent sleep inducing antipsychotic. They fall asleep, they're happy, but then over time, it's not maybe the best option.
Yeah, well, that is. I mean, I'm currently really working with the geriatric population. This is the same recommendation that the sleep hygiene is the main things that needs to be done, and also the use of any medication for any individual has to be reevaluated after a period of time that we are expecting the patient may suffer from that particular problem. So you're right. When they start the medication, I have seen, someone, start the medication for any reason that is a short period of time, they need to be reevaluated, especially in older people. They recommend that in an acute setting, you can use the antipsychotic, for example, for agitation, for insomnia. But within a few weeks, you need to reevaluate and gradually take them off of it. And as you know, as I said, usually 6 to 8 weeks after the detoxification is finished, we would expect to have this some kind of the insomnia related problem with the people that they're coming out of the alcohol. After that, you need to be evaluated. And during that period of time, it's very important to do the sleep hygiene process.
Great. Thank you.
I agree
Yeah.
with you. I mean, those are the medication that has lots of side effect. It does have the metabolic, effect that it
Mhm.
can cause the diabetes and all those stuff. So
Yeah. And I try to talk to them about sleep hygiene or even like CBTI, but it's much easier to take a tablet and go to sleep. So there's
Yes.
a little bit less interest in those topics, at least acutely. Thank you.
yeah.
It's a really excellent point, Aaron, because I think a lot of times what happens on the inpatient side and they come to their outpatient follow-ups and you're like, I don't know why they put them on this medication. I mean, they did, so I guess they should stay on it. So that's a really important point that when we do have those patients and they're transitioning from inpatient to outpatient care, that we really do take a minute to question why we're on this. And I think communication between inpatient and outpatient teams is really vital, and we do not do that anywhere near enough. So it's an excellent point. Thank you. Any other thoughts or comments?
I just wanted to add to what Aaron was saying, and I'm guilty. I do it often when my patients can't sleep. A lot of times the trazodone, the Doxepin, they don't touch it when they've been using a ridiculous amount of fentanyl, benzos, all the things. But I do try to educate the patients as much as possible on the front end, let them know about the side effects. So even if I don't get them on the outpatient side, they're aware this is what can happen. This is what might happen if I'm long-term on this medication. So they can bring it up to their next provider. And then if I do get them on the outpatient side, I try to utilize the sleep hygiene spiels, and we've got some paperwork with that as well. And just reminding them of the importance of coming off of those antipsychotics unless they're warranted. So that's just piggybacking on what you said, but yeah, I'm guilty. I'm 2 nights in. If we hadn't slept, we're doing what we need to do.
Definitely. Well, and it's also without the sleep, some of the things that need to happen aren't going to happen unless you get that rest. So, but yeah, you do what you got to do. But it's that, and I really appreciate, Suzanne, that you're living the life on both on the inside and the outside, between inpatient and outpatient. That gives such a level of understanding of what our patients are experiencing. It just makes for a better fluency when caring for them. So yeah, it's one of those things. Our field is one of those fields that will take everything possible from you, including I sitting here listening to this and I'm like, I've got to change my sleep habits. I'm not doing so well. But we can't burn the candle in 20 different places and be effective. But I do really feel that there's something about the seeing our patients in as many environments as possible so that we have an understanding of what they experience. Not at all what we talk about, except for it's going to impair your own sleep if you're doing everything everywhere. But I really appreciate that you're in both places, Suzanne.
Yeah, I will say I actually really enjoy that because I get to see patients not just in crisis mode when they're rebuilding their lives and getting their families back, starting to work, and just getting involved in the recovery community. And I can really appreciate that because I know up here staff burnout it's huge. And so I wish that I could take the staff with me sometimes to clinic and say, like, this is what we're doing here, guys. Like, I know it's frustrating when they come back 15 times, but here's the result of a 15-time person. We have a CPRS that works at our clinic that was here multiple times. And then, now he's with us in the clinic. So I appreciate it. I wouldn't want it any other way, as challenging as it is something. But it definitely helps me see, okay, these are the results of what we're doing. So let's get up tomorrow and keep doing it.
Keep doing it again. Let's go back and do it again. Because maybe I got 6 hours of sleep tonight instead of 4. So I got a little more energy. Yeah. Awesome. Good deal. Thank you, Suzanne. Any other comments or thoughts? Anybody have a patient that they've been working with that's been particularly challenging in helping them get back to sleep?
I just want to say this is super helpful because almost every patient I talk to has sleep disturbance. And it's difficult to know how to treat them. And a lot of them are on the antipsychotics for sedation and for sleep. And they don't, I don't know if that's why they were started on those medications. But yeah, it's very relevant to everyday practice. Thanks.
Yeah, it is 100%.
I can tell you that 99% of my patients, they have a problem with the insomnia. And the problem is that there are lots of, sleep hygiene needs to be taking place, such as, not using too much of the caffeinated drink in the evening. And also most of the patient that they are a smoker, they smoke or chew tobacco or use the, until they fall asleep. But then 45 minutes later, an hour later, that effect of the nicotine is, resolved, they crave for it. And sometimes, those patients, if they are in candidate of the smoking cessation, it would be better for them to keep the nicotine patch during the nighttime, so they don't have that craving.